Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the multiple audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Canada, Professor Pierre-Olivier Champagne. Prof. Champagne is a professor in the Department of Neurosurgery at the Laval University, Quebec, Canada. He is a skull-based neurosurgeon who specializes in minimally invasive skull-based surgeries by the application of endoscopes. He was a former fellow at the Pittsburgh University, USA, and he is in charge of the Laval University Cadaveric Laboratory, which organizes the yearly Laval skull-based course, and he is a renowned author who has published several articles in various peer journals. We are extremely honored to have him today at our webinars, and today is going to talk about endoscopic skull-based resection for anterior skull-based meningiomas. The speaker for the second session of today is our honorable guest from China, Professor Liu Dianwei. Prof. Dianwei is the director of the stroke center at the Jinan Hospital, Suanwu Hospital, Capital Medical University, China. With 13 years of experience in neurosurgery, Dr. Liu specializes in the diagnosis and surgical treatment of cerebral aneurysms, AVMs, intracranial artery stenosis, and abnormal communicating cerebrovascular diseases. He has completed over 400 surgeries related to various cerebrovascular diseases annually, and he is a leading author in various Chinese core journals and has received multiple level scientific and technological awards in his country. We are extremely honored and grateful to him for accepting our invitation to be a speaker at webinars, and today we'll be talking about the recanalization of chronically occluded vascular pathways via comprehensive surgical strategies. The chair for the first session of today is our honored guest from India, Prof. Prakash Nair. Prof. Prakash is a professor of neurosurgery at the Department of Neurosurgery in Sri Chitra Tirunal Institute of Medical Science and Technology, Trivandrum, India. He is an extremely skilled skull-based surgeon who has proficiency in complex endoscopic skull-based procedures. He was a previous fellow at the Will Cornell University Medical College, USA, as well as the Osaka City Graduate School of Medicine in Japan. He is a renowned skull-based surgeon over the country and is an invited faculty to various skull-based conferences and workshops. And we are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today is our honorable guest from Japan, Prof. Hidehito Kimura. Prof. Kimura is a consultant neurosurgeon in the Department of Neurosurgery at the Kobe University School of Medicine, Kobe, Japan. His clinical interests are focused upon cerebrovascular neurosurgery, especially aneurysm surgeries, AVMs, and bypass. He is an integral part of the ACNS delegation to various countries over the years for the demonstration of skilled bypasses, and we are extremely honored and grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Prof. Yuko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. With that introduction, I would like to hand over this podium to our first chair, Prof. Prakash Nair.
Thank you so much, Raja, for a very kind introduction. Without taking much of your time, I invite Dr. Pierre-Olivier Champagne to speak on the management of anterior fossa meningiomas. Over to you, Pierre.
Thank you. I'll just share my screen. It shouldn't be too long. All right. So thank you very much for this kind invitation. Thank you very much to the ACNS for allowing me to talk to you today about one of my favorite subjects, which is the endoscopic endonasal approach for anterior skull-based meningiomas. Without further ado, I will start. So I have no conflict of interest to disclose today. So endoscopic endonasal approach for anterior skull-based meningioma, or for meningiomas in general, remains a controversial topic. If we go back a little bit about the notion of expanded endoscopic endonasal approach, we have to remember that we started endonasally to expand the corridor and expand the approach, starting with sinonasal malignancies and then going into intracranial pathologies through the dura at the end of the 90s. It seemed like the natural extension to go from the sinuses in the nose all the way into the skull base and into the brain cavity. Then we know of the seminal papers and the work in the early 2000s of notably the Pittsburgh group about how we can expand the endonasal corridor and go a little bit further both in the sagittal plane and in the coronal plane. You can see here some of the meningiomas that they approached in the early 2000s, tuberculum cellae, as well as olfactory groove meningiomas. I like to think as the endoscopic endonasal approach in modules in the sagittal plane, starting with the usual and the most the standard approach, which is the transcellular approach, and then moving up to the transtuberculum or transplanum corridor, and finally more anteriorly through the transcribiform corridor. So let's have a case. Let's take a look at this one and ask ourselves, how do we approach this case? There's many ways to skin that cat. We can do a transcranial or terminal approach. We can go also transcranial, but through a more minimally invasive approach using an eyeball approach. And we can do endoscopic endonasal using the nasal cavities to approach this. I think all of these options are valid, and there's many ways to operate such tumors. So how do we choose between these corridors? I think that for any meningioma or any skull-based cases, we have to apply the same principle for open and endoscopic approaches. So is endoscopic endonasal EEA a good corridor for meningiomas? First, we have to ask ourselves, what is a good approach? What makes a good approach? So here's not an exhaustive list of what I think are the main proponents of a good approach. So we have to have a good surgical access. So we have to assess the lesion in its long axis. We have to have good surgical freedom, being able to move. We have to choose an approach that minimizes brain retraction to respect the brain parenchyma. We try to avoid as much as possible to cross neurovascular structures, nerves, and vessels. We, in the case of meningioma, try to achieve a Simpson grade 1 resection as much as possible. And we also have to take in consideration the morbidity of the approach, the time that we have to take to get there, the complication related to it, be it crossing certain cranial nerves or, of course, CSF leak. So going through this list and talking about surgical access, first, I would like to talk about how is the access with the EEA. So I think the EEA is best suited for midline meningiomas, tuberculum sellae or planum, and olfactory groove. I was lucky to be part of this international tuberculum sellae meningioma study, and we demonstrated that EEA is better for visual outcomes when talking about tuberculum sellae meningioma, and has more chances to offer a more complete resection, and of course, Simpson grade 1 resection. These are some of the dissection from our lab. We see, of course, the sella, and when we go upward, it is really the natural extension to go through the tuberculum. But we also always have to remember all of the anatomy that's around us and what's underneath the bone, be it the optic nerves, the ICAs, lateral OCRs, clavicle recess, and of course, the sella and the pituitary gland. And when we remove that bone, we go now into the dura and we see much better all those structures, being the ICAs on both sides, pituitary, and the chiasm. I like to approach them is doing a midline incision, trying to preserve the superior intercavernous sinus and cut it separately. And then we can go and see all of the usual normal anatomy that we can see here on this section from our lab with the stalk, the optic nerves, the chiasm. And if we look with an endoscope, or if you just look on the sides a little bit more, we can see, of course, the supraclavian ICA, the distal dural ring, the ophthalmic artery that will run in the inferior portion of the optic canal, and very importantly, the superior hypophyseal artery, which goes to the stalk, but also gives branches to the optic nerve, and it really is an important artery to maintain and preserve when we operate on these cases. Same thing on the other side. So now a little case just to showcase how we approach these out of our center. It's a 57 years old woman who presented with an incidental discovery of this supracellular mass. It looks like a tuberculum sellae or a diaphragma sellae meningioma. So if we go back to our list and see, okay, what makes a good approach? Would the EEA be a good approach for this tumor? So we have a good surgical access straight to the lesion with no brain retraction. We have a good access to the dural implantation, so a good chance at the Simpson grade 1 resection. And we are not crossing any nerves or vessel. We are underneath the chiasm, between the ICAs. So we have, I think, an ideal corridor to remove efficiently this lesion. A small video showing how we approach it. So we always do a surgery with the ENT. We can see the usual intrasphenoidal landmarks with the ICAs on both sides and the pituitary in the middle. In this case, since it's a relatively small tumor, we prefer to open small and then make it a little bit bigger if needed. So we always want to have a lot of mobility. So I'll always remove as much as possible of the anterior face as sphenoid. And then but for the dural exposure, I go a little bit more minimally in that case. So we do the dural incision in the midline, as showed previously on the anatomic dissection. I like to coagulate and divide the superior center cavernous sinus. It gives us also as low as we can get on top of the pituitary to be able to really remove the meningioma. And then using a McElveen knife, we go towards the optic canal on both sides, always trying to expand from the midline, then laterally. And then we are right on the lesion. So we start with the bulking. And we apply the same microsurgical technique and principle that we would do in a standard transcranial case with a microscope. So we are seeing arachnoid, we have to cut the arachnoid membrane and the arachnoid that's on the tumor. And then we can see right here this nice little supraapophyseal artery in the pituitary stalk. So we have to dissect the artery from the tumor. So again, we're using the same principle. We put a little bit on the tumor, we see where it attaches. And in this case, it was a little bit adherent to the tumor. So we decided to cut into the tumor and leave a little cuff of the tumor capsule onto the superior apophyseal artery in order not to injure it and to preserve the vascularization going to the optic chiasm. So once it's nicely detached, we can keep on going with sharp dissection on both sides. Now we're cutting the attachment at tuberculum celli. Always be mindful of the ophthalmic artery at this point, and of course the ICA, not to injure it. And then we can just remove this final part, and the whole tumor is out, and we have Simpson grade 1 resection with good coagulation and preservation of the stalk, the chiasm, and the superior hypophyseal artery. Then starts the reconstruction. After this point, we use a multi-layered technique using an inlay fasciolata, followed by an onlay fasciolata, followed by the standard nasoseptal flap. And then we use packing to hold everything in place and fibrin glue. The patient evolved well postoperatively. She had a complete resection and an uneventful postoperative period. So once you start doing these cases, then you can start you can choose these ideal cases for EEA, as shown in this one superiorly. Another case that's really not too big, really well located. You have a complete resection, and then you can start going a little bit more laterally, such as in this other case. And then you can tackle some bigger tumors, especially this one I think is perfect for endonasal because it really is behind a really steep tuberculum celli that would be really hard to get through a standard craniotomy. And you can also tackle some bigger tumors with some start of a vascular encasement. So when we start to go beyond these ideal cases for tuberculum celli meningioma, I think that's the lateral extension starts to be the limits. And how can we maximize our lateral extension is via a region I like to call the supraoptic triangle. So let's see this case. So we have this case tumor that goes lateral almost, at the level of the attachment of the anteroclinoid process, but in between we have here the optic canal. So if we want to go remove that tumor, we cannot go through the optic nerve. So it violates the principle of crossing neurovascular structures. So how can we maximize that? So the same patient here, it's a 64-year-old woman with left optic neuropathy. We have now this tumor. I like to use T2 to visualize well the optic nerve. We can see it very well there. So there's a big displacement of the optic nerve. And if we move from anterior to posterior, we see that the tumor really lateral on the left might be tough to get. So we have the optic nerve right there, more posteriorly, and even more posteriorly, we have some tumor on the other side of the ICA. So how can we maximize this lateral corridor is via this this region. I like to call it, some people call it the supraoptic or recess, but it's not really a recess. It's more like an area of bone. That's why I like calling the triangle. And I have described this in a paper with the Pittsburgh group when we defined this this triangle up top of the optic nerve with inferiorly the canal, superiorly the plenum, and laterally the lateral portion of the optocarotid recess. And when we drill this, we can get more lateral access superiorly towards the anteroclinoid process. If you look at this reconstruction on cadavers, we can see that the amount of bone removed is really the superior portion towards the enteroclinoids. So another nice dissection from one of our fellows at the lab, we can see the supraoptic triangle on the left. And once it's nicely drilled, we can see what kind of more lateral extension we can get towards the enteroclinoid process. So here's a video of that patient. Again, here tumor is a bit bigger. We need more extension, so we drill a little bit more towards the planum. And so we start, as usual, drilling the sella. We expose this first, and then we move superiorly to the tuberculum. You can see the tuberculum is thick and involved with meningioma. And then we move superiorly, so we go above the optic nerve and we remove the planum. Again, the planum is just like the tuberculum, seems to be quite thick and involved with meningioma. And this is the drilling of the supraoptic triangle on the left side. So we use continuous irrigation not to injure the optic nerve with heat. We go on the other side as well. Once it's done, we can see the usual landmarks and the supraoptic triangles on both sides that have been drilled. And we can start opening dura in the same fashion than previously showed. We do the dura opening in the midline using, again, the McElveen knife. And then we proceed to some arachnoid dissection in the same fashion than previously showed. Again, we remove the dural attachment on the right side, starts where we can see the nerve and then we can follow it. And then we really take advantage of this supraoptic triangle on the left side and for the attachment. We do some of the arachnoid dissection, and then it's time to debulk the tumor. Same as we would do through a transcranial case. We use the CUSA, and then we move on to the arachnoid dissection again, exposing more and more of the nerve. Again, tumor removal at the level of the supraoptic triangle on the left, using traction, contratraction. There was a small vessel going atop the tumor and doing a little loop, really en passant vessel, so we have to dissect it and keep it on the brain side. Then we open the optic canal in order to release the pressure on the nerve and remove really completely the tumor. Then we start doing dissection above optic nerve. We really are ungloving the optic nerve from the tumor. So there's a lot of tumors on the nerve. We have to be very careful in this region not to injure the nerve. And this is the final view of the tumor that is completely removed with the ophthalmic arteries on both sides, the A2, the stalks, and the stalk and the optic nerves. And then we do our reconstruction as shown in the other video. She had a good visual improvement post-op. We have a complete resection. There is here the more lateral portion here that really represent what we thought might be tough to remove, but we see here that we really we were able to go more laterally. So now what happens if we try to move a little bit more anteriorly? So we talked about transplanum, transtuberculum. So now let's talk about olfactory groove meningiomas, the transcribiform approach. Olfactory groove meningiomas are a bit more controversial than tuberculum celli. So what are the advantages of EEA, I think, for olfactory groove is that we have less cerebral retraction. It makes your life easier with early devascularization, and it's your best chance at a Simpson grade 1 resection. Of course, the drawbacks of the endonasal is CSF leak, the lateral limits, so you cannot approach all of the olfactory groove meningioma through this approach, and of course, loss of olfaction. For me, it's very important for the patient to understand that if there's olfaction left, I will not propose this surgery or this approach first, endonasal. So let's go with a case. So 72 years old, she has headaches, cognitive loss, some personality changes, and we have this tumor. So olfactory groove meningioma centered on the midline with really important hyperostosis, edema, and this weird superior shape. Here's how I like to approach it endonasally. Again, it's a nice dissection from the lab. So we have to remove all of the ethmoid septations, and we do a craniotomy that starts posteriorly at the level of the planum and goes all the way anteriorly at the level of the ethmoids and the cribriform plate. So we remove the lateral lamellas first after the cribriform plate. And then we remove the planum more posteriorly, depending on how we want to tailor the approach, and remove the meningioma. We also removed the crista galli, and this gave us this kind of view with the redundancy in the dura. And then we do dura opening on both sides, bringing it more posteriorly toward the end. And never forget to cut the falx attachment horizontally to be able to completely detach the dura. And we see the falx attachment superiorly, olfactory bulbs, and the usual landmarks of the anterior mesophilic fissure and orbital arteries. So this is the video of this case. I'm going to showcase a little bit of how we approach it. So it's more work for our for the ENT in this case, because we have to make a lot of place in the nose. So we unlike the other cases of tuberculum meningioma we showed, we like to remove both of the middle turbinates. We raise the nasal septal flap, and then we work anteriorly. As you saw in the images, this meningioma goes really anteriorly, so we have to maximize the anterior approach. In this case, we do what we call the draft tree frontal sinusotomy. So we unite the both frontal sinuses to be able to see the curvature of the skull base anteriorly with the frontal sinus. Another maneuver that helps you get more lateral is exposure of the periorbita by removing the lamina papyracea on both sides. Then we move on with the craniotomy, starting posteriorly and moving anteriorly. You can see that the bone here is really thick, so we have to get through all of that bone to reach the dura. And while you're doing this, you get onto the ethmoid arteries, so you get an early devascularization of the meningioma to this approach. And then you remove both lateral lamellas on both sides. And again, this is the really big middle part. All of this involved planum, hyperostosis. We can remove that. That will be very difficult through a transcranial approach. So, and then we can remove this whole involved bone and get this really nice access to the tumor. We also remove the crista galli. That's also a little bit big and involved with meningioma. And then we really maximize our lateral corridor, and then we do the dura opening. So as shown on the dissection, we go on both sides, and then we cut the falx horizontally to be able to detach it. And once the falx is completely cut, we got this nice access to the base of the tumors. And again, same principle as we would do in a transcranial approach. We go with debulking, and then we alternate with extracapsular dissection. We go back to debulking. You maybe remark that we're using patties without we have to cut the little rope on it because it would take too much place in the nose. So again, we alternate extracapsular dissection, debulking, and we remove that final portion. I think we had to cut it because it wouldn't fit through the nose. So that's the final cavity. So again, we inspect it. We make sure that there is no attachment to dura. This one was one of our early cases. We used Duragen as an inlay before putting our fascia lata. Now, I think if we were to do this case, now we would use our standard 2 layers of fascia lata, both inlay and onlay. In those early cases, we also use, of course, fascia lata as an onlay fashion before putting the nasoseptal flap. You will see that the nasoseptal flap is not big enough to cover the defect, so it's really important that you have a nice fascia lata that is kind of an extension of your nasoseptal flap. And then we use packing, Surgicel, fibrin glue, to hold everything in place. All right, so this is the post-op MRI that shows a complete resection. And it came back as a grade 2 meningioma. So I think this case showcases really well the advantage of endoscopic endonasal for such a case, because we have a complete resection, a real Simpson grade 1, and that patient now is disease-free with no radiation from a grade 2 meningioma. So I think we had the vertical surgical access, no brain retraction or really minimized brain retraction. We didn't cross any neurovascular structure, and we have a good Simpson grade 1 resection. Same as for a tuberculum celi, we have these cases that are kind of ideal for endoscopic endonasal that are on the midline, that project superiorly. They can be smaller, they can be bigger. So this is one of our bigger cases that we did. But again, complete resection and an early case at the bottom, since we don't have the MRI yet. I was lucky to participate in this publication when we described the evolution of endoscopic endonasal approach for olfactory groove meningioma. And what we've seen is through the years is that the technique evolved, and I think it became really, for a selected case, a really good approach. We really minimized the brain retraction and the imprint of our passage with good resolution of post-op edema. And CSF leak has diminished to 8% in these cases, still higher than transcranial, of course, but I think it's really acceptable. And the percentage of extent of resection is quite high, and I think it's the highest reported rate of Simpson grade 1 resection, 68%. So same as for tuberculum meningioma. So how can we maximize it? What are the limits? I think, again, it's lateral. I would say that the lateral extension maximal would be the mid-orbit on the olfactory groove meningiomas. And how can you get there to this mid-orbit is by removing fovea ethmoidalis, and really by exposing the periorbita. Coagulating and cutting the ethmoid arteries really allows you to push the periorbita and go more laterally over the orbit. An example here, it's a 46-year-old woman with personality changes, anosmia, headaches, and blurry vision. She had bilateral papilledema. So we have this quite sizable meningioma here, and we can see that it really sits into the anterior fossa with a big slope. She has a slight extension behind the mid-orbit, so I thought it was a limit case for an endoscopic endonasal approach. She has a lot of edema, and so we decide to go endonasally. Of course, she lost olfaction too. Same approach as shown in a previous video. We make some room in the nose, we open all the sinuses, and then we remove this central hyperostosis, and we do the craniotomy in the same fashion, starting posteriorly over the optic. You can see the preorbita, the sella, and the ICA. And we start the bone removal more laterally, and then going more anteriorly. So we remove all of this thickened and involved bone. So I think it really gives us the good access. And as we go, we divide arteries. So you'll see once we've done this, we can really push the periorbita on one side and really maximize the lateral corridor. So this is what we're doing here between periorbita and dura. We push on the periorbita and the dura, and we get here on the fovea ethmoidalis. Also, you have to remember when we coagulate the ethmoid arteries, to do it as much as possible, as far away as possible to the periorbita, because what we don't want is for the artery to retract into the orbit and cause an orbital hemorrhage. I've never had it personally, but we always think about it when doing it. So again, we coagulate and divide the ethmoid artery, and in the same fashion, we remove this fovea ethmoidalis above the orbit, allowing us to maximize the lateral corridor. So we push on the orbit, push a little bit on the dura, and we can then start in the same fashion with dura opening. You can see that we have this very wide corridor, so we really maximized the corridor on the coronal plane. And then we can do, again, as showed in the previous video, resection going with debulking using the CUSA, and then extracapsular dissection. So you can see also how the tumor doesn't bleed, since we really cut all of this vascular feeder, and then we can remove this last section. And this is the final view once the tumor has been removed. We do reconstruction as shown in the other video. Our post-operative period was uneventful. She had improvement of vision and cognitive symptoms. We had a complete resection, and also, importantly, a resolution of edema. So now time to talk a little bit about morbidity of the approach. So I think we always have to be mindful of vascular anomalies and vascular structures. That's regardless of the approach, but particularly true in endoscopic endonasal. So we have a case of a 59-year-old woman with left optic neuropathy and a little bit of a vision loss. we take a look at this meningioma, and it really looks like an ideal case for endoscopic endonasal. It's midline. There is no crossing on vascular structures. There is slight compression of the left optic nerve that explains the optic neuropathy. The slope of the tuberculum cilia is like almost 90 degrees. So if you want a good resection, I think, again, EEA is the way to go. We see here the left optic canal invasion. EEA is also, according to me, the best way to get into the optic canal, the medial part. But here is the catch. There was an aneurysm inside of the meningioma, really embedded into the tumor. So we always ask for an angioscan for all of these cases to be able to see it. So it would have made the resection much more dangerous if we haven't seen this. So having seen this, we decided to embolize the aneurysm prior to surgery to make the surgery much safer. So then we can approach this case as in any other case, just being very careful when we dissect it from the dome of the aneurysm. So we dissect the tumor from the optic chiasm inferiorly, and then it's a very soft tumor, so it makes our life a little bit easier. We can see the arachnoid dissection, so we move really slowly towards where the dome is to go and see our aneurysm. And we can see the inferior dissection from the optic chiasm. We want a really circular view to be able to dissect the tumor from the arachnoid around the aneurysm. And then we can see the aneurysm that's being completely embolized with no circulation, the optic chiasm at the end. So we are really happy with this resection once it's done, and it's been done, I think, in a safe manner with prior embolization. The patient has a complete resection. Vision remained at baseline. Here's another case of a 65 years old woman with a right optic neuropathy. Again, tuberculum cilia meningioma, that seems quite perfect for endoscopic endonasal. It goes a bit more anteriorly. We also have to go a little bit more to the right through the supraoptic triangle. So again, in the same fashion, we open on the midline. We arrive on this tumor that's well devascularized. And also, lucky us, it's quite soft. So we don't even have to use the QSAF for such a case. There is no real capsule or membrane. We're really happy with it. So we're just using suction and nothing too sharp. We go around. We go superiorly into supraoptic triangle, and then it's time to decompress the nerve. And we're almost done. We just want to get rid a little bit of the arachnoid on the left. So there's the optic nerves, the optic chiasm, superior apophyseal. So we're dissecting here with a scissor, trying to get rid of this involved or taking arachnoid, and whoops, this happens. So let's pause a little and see exactly what happens. So we go back a little bit, and we see here, so we're with the scissor, we're not really cutting, just using the tip of the scissors, and something starts bleeding on the ICA. And when we go back on the preoperative MRI, there's something we missed, which is this. There was a small blister aneurysm that was inside the tumor as well. And now with our scissors, we just touched it and grazed it, and it starts bleeding. So we have a major bleeding of this small blister aneurysm on the ICA. So we have to control it. So first, we use patties to do local compression. We started then also to use our bipolars to try to coagulate it. Didn't work. And then we brought in some clips to see if we could clip it. Always assess also during the surgery, we assess the completeness of the polygon of Willis to see if we could sacrifice the ICA. And then we brought in some clips to see if they could fit. This one couldn't fit, so we tried some others. And during that time, slowly relieving pressure, we achieved local hemostasis. So then we went back to the thigh when we harvested fascia lata to be able to harvest a muscle graft that we crushed to help with local hemostasis. We put some oxidized cellulose, then our muscle patch on the region that was injured, and then over this we do a reconstruction. So we chose to do our standard reconstruction with inlay fascia lata, onlay fascia lata, and then putting the nasal septal flap on top of this. Of course, After surgery, we go straight to the angio suite to see what happens. So you see on the left side, this small blister that's there, and a couple hours or days later, it's getting bigger. So we have to treat it. So we decided to treat it endovascularly using a flow diverter, and that did the trick. Apart from this, our post-op period was uneventful. Vision remained at baseline. It's a fairly recent case. We don't have the MRI yet. So we always have to be mindful of vascular anomalies. Also, another thing with the approach is leaving residual disease. Sometimes we have to choose to leave some disease behind. This is a 33-year-old woman with a right optic neuropathy. Again, we go endonasally to remove this meningioma, and you could see that there was a big imprint on the right optic nerve. So we are here trying to dissect tumor from the optic nerve, and we see that it's getting more and more difficult. And we have the impression that the tumor is above the optic nerve, but it's not true. In fact, the optic nerve has been splayed and is really thin, and it goes all the way up there. So we have to trying to dissect it from the nerve is getting really difficult. And we know that if we pull a little bit too much on this, we will injure the nerve and the patient will suffer from it. So what we do is that we chose to keep a little bit of the tumor on the nerve and just detach it from the dura and keep this thin portion of tumor on the optic nerve, not to injure it. So that's a decision we took. I think it's the same that I would have taken if doing this case transcranially. So I think that was a good decision for the patient, because the patient, of course, she had the expected residual on the optic nerve, but her vision improved. And what happens with those meningioma remnants? This is from a study that we are currently doing, so it's still unpublished data. But when we took a look at those remnants, those that have no dura attachment, so that are devascularized, they show a growth that's much less than these other meningioma remnants. Also, speaking of agents to help with the safety, so we started to use ICG, so endocyanate green, for our cases. So this is another case of tuberculum celi meningioma. This is at the end of the case. We really like to use ICG to show all of the vessels, and also how the optic nerves and chiasm light up using the ICG. We are currently studying with other groups how ICG captation from the optic nerve helps predict the visual outcomes in such cases. So this patient also had a good resection. Another case here of olfactory groove meningioma. So it's another fairly big meningioma, but this one we really had a nice and clear plane between the brain and the meningioma that has been completely devascularized from the approach. So again, as shown in previous video, we do this gentle dissection of vessels that are passing by. We alternate between arachnoid and extracapsular dissection and debulking using the CUSA. And in this case, we're still doing the dissection, and we can see that there is no brain retraction. We really are transforming this skull-based meningioma into a convexity meningioma case, where we can really view all of the brain that's there and do a nice job at the resection, minimizing brain retraction. So we remove this last portion at tuberculum, and then at the end, in the same fashion, we use ICG to confirm vessel patency and to make sure that there is no meningioma left on the meninges. This patient also had a complete removal. It's also a fairly recent case with no MRI yet. Also, but that patient had a CSF leak. Fortunately, we just had to go back and repair the leak, and the patient had no other adverse effect. But it's the main drawback of EEA. You cannot talk about doing such big approaches and not talk about CSF leak. In our series, it's 9%, and we are still working to minimize it. I mean, we just recently published from our group the development and validation of a new cadaveric model to reproduce CSF leak. It's a model that it's quite simple. We're using a ventricular drain on a cadaveric head and a fiber optic pressure, intracranial pressure. The drain is positioned in the interpedicular cistern, and we pump water into it. You see the video here that shows on the cadaveric head, when we open and the pump is in function, and when we open the arachnoid membranes, you will have a flow of water in this case that mimics the CSF flow. And to make sure it came from the pump, it's not just liquid from the cadaver, we colored the water from the pump in blue to make sure that it was indeed our artificial CSF that was coming out. We validated this with different closure techniques, and we can see that it correlates well with operator experience, both in success of repairing leaks through this model and time taken to do it. Also, some words of microdissection. You've seen a little bit on it, but I think it's really important when we do endonasal surgery to keep the same principle that we would have in open approaches of microdissection. And so as we approach the scope, we can get a better view, and we can really do microsurgery the same way we would do with a microscope. So we just have to take our time and dissect vessel and preserve parenchyma. So in this case, there was this vessel that was stuck to the tumor, and just by taking our time and cutting the arachnoid around the vessel, we're able to preserve it and do a good microdissection for removal of this tumor. Again, showing the final cavity. All right. And we had a complete resection too in this smaller case. And just one last case, I don't want to take too much of your time. So showing how we integrate everything. So we have this tumor, that's a case I think we did 2 weeks ago. She's a 64, she presented with anosmia, right optic neuropathy, personality changes, and we have this tumor. If we go back to our initial slide, so what makes a good approach? So for this tumor, we have access to both, so it's kind of both of an olfactory meningioma, but there also is a tuberculum cell component to it. There is also tumor and an involvement of the supraoptic triangles with encasement of the optic nerve. As you can see on the image, the optic nerves are completely encased by the tumor. There's also a lot of edema, so we expect to minimize brain retraction when endonasal approach. And talking about neurovascular structure, we also have ACE encasement. So for me now, it still is. I'll still be very cautious going endonasally when we have encasement of major vessels. So for me, there has to be minimal encasement for me to go endonasally. In this case, I found it to be minimal enough so that we would go. And there's also a nice now with ICG, I think we are much safer doing these cases endonasally. We, of course, have the best chance of Simpson grade 1 resection in this case. So our last video to show this case that kind of integrates everything we've been talking about. So same approach. So it's a bigger approach both for transtuberculum, transplanum, cribiform. Again, we go with coagulation and transection of both posterior and anterior ethmoid arteries. So after coagulation, we cut it as far away as possible to the orbit. And then you can see once it's done, we can really maximize laterally as we push the periorbital laterally. And then we remove the involved tuberculum. On the right side, there's the supraoptic triangles. So we maximize our lateral corridor also posteriorly by drilling both of the supraoptic triangle, always using continuous irrigation when we are on the optic nerve to make sure there is no heat damage to it. And we really try to maximize towards the interclinoid process this way. This is before opening dura. We can see all of these landmarks. And then we start resection as shown in the other videos. So really go with extracapsular dissection, and then we use ICG, and we can see the A2 on top, so we decide to leave it alone for now, and then go back inferiorly to tumor dissection from the optic apparatus. So again, we maximize resection at the level of the supraoptic triangles, and we use our patties to protect the nerve, and we do. Now I'll go back to the superior portion using ICG. So now we can see both of the anterior cerebral arteries, and we can see them a little bit through the tumor, so we can manage to kind of guess where they are. And there's this vessel that goes from the anterior cerebral artery, and we don't know if it's the tumor vessel or an en passant vessel. So we have to be very careful, dissect it, and see where it goes. And that's here. I think that here that ICG is really helpful, is that we can, if this vessel's being coagulated further down, it won't catch on ICG, and that's exactly what happens. So there is no flow going into this vessel. So it really confirms that it was a tumoral feeder that has been sacrificed down the road. So now we can coagulate it and cut it to be able to safely dissect the tumor from the anterior cerebral arteries. So we can go ahead and remove the last part, and this is our final view with both optic nerve, pituitary gland, and the A1 superiorly. Again, she had complete resection, but again, it's on the basis of CT scans. So we take this with a pinch of salt. She had a small worsening on her vision of the right side, which she already had a optic neuropathy on that side. So now, just to conclude my talk, I think that so EEA is a valid approach, but for selected cases, we have to follow the same principles for EEA than in open approaches. So aiming from a Simpson grade 1 resection, using the same microdissection principles as in open approaches, and of course respect of neurovascular structures. There is always some morbidities more pertaining to the approach, CSF leak, all the sinonasal imprint, and of course olfaction. And I really think that EEA complements the neurosurgeon armamentarium. So it has to be one of the approach that we can propose and that we can think of, but we have to take it in the bigger picture of all of the approach that we can offer to the patient when choosing the ideal approach. So I would like to thank you again for listening, and thanks to the ACNS for the kind invitation. I would also like to thank my skull-based team working with me, especially the lab fellows and clinical fellows that helped me work on this presentation, especially on the videos and the dissections. And finally, I'd like to extend to everyone an invitation to our annual skull-based hands-on course in Quebec City. So the next one's going to be in June 2025. So we can save the date. And if you want more information, of course, you can always write to the address that's on the screen. Thank you very much.
Thank you, Pierre. I mean, it was a really wonderful talk where you covered a very large section of how we should manage anterior for some meningiomas. You've also highlighted the fact that, the middle optic canal can be explored extremely well. And you've shown a wonderful example of how the anterior and the inferior aspect of the optic chiasm, which is not very visible when we come in through the transcranial route, was very well seen. So we're able to protect vasculature much better and give patients much better visual outcome. So to just carry on discussion, I'd like you to tell us how you manage these patients after surgery in terms of lumbar drainage, nasal cleaning, and those details.
Absolutely. Very good question. It's always tough to try to fit everything into the talk. So we do use lumbar drainage in every time we have a high flow CSF leak. So we use data that was based on the trial from the Pittsburgh group, which shows that really there's a diminished leak, CSF leak from use of lumbar drainage. We use it for 3 days. So it's 3 complete days at 10 cc's per hour. And we also put endonasal packing going and mesh going all the way to the nose. We remove these usually 3 days after surgery, and then we do our first endoscopic exploration 2 weeks after surgery, usually when the patient comes back from home.
And when you have a patient who has CSF leak, what is the algorithm you follow? How early do you take them in for re-exploration?
I would say as early as possible. For us, it's we view CSF leak from these from these post-op CSF leak. For us, we will usually, if it's early in the day, it's going to be the same day if the patient hasn't eaten, but usually it's the day after. So let's say the patient comes back, we see him in the emergency, we confirm a leak. Sometimes there's these cases when you're not sure. So is the patient leaking, or is this just the nasal solution that's dripping? For these cases, what we do, we always go and explore them in the ENT clinic, and we see with the scope. If we're convinced, then we go to the OR. If we're not convinced, there was also this nice technique that has been described by the Italian groups, Luigi Cavallo, when they use the Friben glue just in the clinics. So it happened to one of our cases. It took two cases of us. It worked really well. So there was some doubt of a leak. So we hospitalized the patient for 1 to 2 days. We put him on bed rest. We used the fibrin glue, and it did the trick. But if we're convinced of our leak, we'll always go straight to the OR.
And what about your antibiotic prophylaxis and your DVT prophylaxis in these patients?
Very, very good question. So we're a little bit scared. So we use like large spectrum antibiotics. Yeah, I don't. So far, we didn't have any, apart from one case of a leak, but it wasn't on a meningioma where that had a real meningitis. But we use ceftriaxone for 2 days and cephalosporin orally for 5 days after that, as long as the patient's in the hospital.
And DVT prophylaxis?
DVT, yeah, standard heparin after day 1.
Keep heparin going till you have the lumbar drain, and once your lumbar drain is out, to stop heparin and ambulate the patient.
So we keep them together, but the morning we remove so we manage lumbar drain with anesthesia. So that's a load off of our shoulders. They think about the lumbar drain, and we can think about anything else. So we just prescribe when we want it out, and the morning of the drain removal, they hold off the heparin. So then we remove the drain, and then we keep going with the heparin.
Yeah, so I completely agree with you. Keep putting the lumbar drain in OR once the patient is in anesthesia is much better than doing it after surgery when the patient coughs and sneezes and puts pressure on the repair. And we have been giving patients dabigatran, oral dabigatran, so that their compliance is better. So that helps in the first 3 days. So one other question before I hand over the mic to Dr. Raja, and that is regarding your regarding lateral extension, which you talked about with the description of subtropic triangle. So do you also have a definite limit, where you decide that, no, I'm not going to do this endonasally, but I'm going to come for this through either an eyebrow or for a transcranial approach?
Yeah, I would say so. For me, it depends for tuberculum and an olfactory groove. For me, olfactory groove, it will be the mid orbit. If it transgresses the mid orbit, I don't think it's a good idea. But sometimes you can have surprises that it seems to be attached to dura, but you can go a little bit more lateral. And always for these patients that are kind of on the limit, I always tell them that we might not be able to remove it completely endonasally, and we might have to complement with the transcranial approach. It's always on the table, and you have to be transparent with them. I think it was Danny Privadello that described for big olfactory groove meningioma, he first do endonasal debulking, and then he completes with a transcranial approach. So I think it's very valid. And for the transtuberculum, for me, if it goes onto the anteroclinoid process, I think for me that's the limit. Like the real ACP, not just the attachment. You can get on the attachment with supraoptic triangle, but if it goes really on the anteroclinoid process or on the other side of the optic, for me it's a no-go for endonasal.
I agree with you. Actually, you started your talk with the heading, that anteroclinoid fossa meningiomas are controversial, and I think one of the reasons why a lot of surgeons have a lot of doubts before they approach on us because meningiomas tend to have variable consistency. So when you have a soft tumor, it is easy to access onto the top of the optic nerve and to the surface of the IC and resect it. But when you have fibrous tumors, especially hard tumors with the arachnoid planes are especially difficult. Those planes are difficult to access, and that is where you might have to debulk, spend a lot of time dissecting the tumor against both the arachnoid and the vessels, and that is where we have difficulties. So I think Pierre, you've covered the whole gamut of ACF meningiomas very clearly. I thank you so much for such a wonderful talk, and congratulations. So I hand over this to Raja
for having me and for the nice questions and comments.
Well, thank you very much, Pierre Champagne and Prakash, for this excellent session. I would like to open the house for discussion. If there are any questions, we can take 2 short questions. But start from me. I would like to ask that fat has always been an integral part of endoscopic reconstruction all over the world. Surprisingly, we did not see that in your videos. Why?
For reconstruction algorithms, I really stick to. So I think fat is really popular in Italy. I use it. I don't. What I don't like with fat for endonasal is the space it takes on the in the cranial compartment. So having a big chunk of fat doing kind of the snowman. I'm not a huge fan of that. I use fat sometimes just to patch little holes I see at the end of reconstruction after putting our inlay fascia lata. I think it's good for this, but there's in so many different algorithms for reconstruction, and many people use fat with success. I'm certainly not saying it's not good, but for me, I think this multi-layer I showed works well, and I use fat differently, but it's just not really in my for most of my open approaches. When doing Kawase or even interclinate, I use fat a lot, or combined petrosal and stuff like that. Then I change gear a little bit and use much more fat for these, but endonasally much less. But I think it's pretty good. But our approach works well for us.
Thank you very much. As you mentioned, Prof. Cavallo is one of the popular technique is the 3F technique, which is fat, facial, and fibrin glue. They have very good results with that, but depends on which place you are and what is your practice. So if there are no further questions, I think we can call it a day. Thank you very much, Prakash and Prof. Pierre, for this wonderful session, and we're extremely grateful to you for teaching us no answers of endoscopy.
Pleasure was mine.
Thank you very much. So I'll update all our viewers that we have broadcasted this on YouTube, WeChat and Zoom, and as of now we have around 910 people who have joined from all across the globe on different streaming channels. So we will move on to the second session, and I hope Prof. Liu Dianwei and Prof. Hidehito Kimura are ready.
Yes, I'm Hidehito Kimura from Kobe University. I'm very glad to introduce the second speaker, Professor Liu Dianwei from China. And thank you very much for joining us. Now, today he will talk about the recanalization of chronically occluded vascular pathways by a comprehensive surgical strategies. I've been looking forward to hearing this fantastic presentation. So, Professor Liu Dianwei, please start your presentation if you are ready.
Distinguished chairpersons, honorable professors, hosts, and fellow attendees, good day to all. I am Dr. Shao Qiang. I am deeply honored to be the second speaker on behalf of Professor Liu Dianwei. This esteemed ACNS academic conference, sharing a clinical case with you all. The theme of my presentation is the recanalization of chronically occluded vascular pathways via comprehensive surgical strategies, with a specific case study titled "A Case of the Recanalization of Chronically Occluded Left Internal Carotid Artery via Combined Surgical Strategies." Chronic internal carotid artery occlusion, CICAO, is a significant cause of stroke and ischemia, accounting for 13% of all stroke etiologies. In the United States, the annual rate of ipsilateral stroke due to non-selective CAO ranges from 2.1% to 3.8%. Among patients receiving medical treatment, the annual incidence of ipsilateral ischemic stroke is 3%, which increases to 10% to 20% when severe cerebral hemodynamic disturbances are present. The etiology of CAO, chronic arterial occlusion, is intricate and multifaceted, with atherosclerosis accounting for overwhelming 70% of cases, making it the primary causative factor. Moreover, arterial dissection, as another significant contributor, accounts for approximately 20% of cases. It is also worth noting that other factors such as cardiogenic stroke cannot be overlooked as causes of CAO, and together these various factors constitute the complex and varied etiology of CAO. The rate of post-operative vascular recanalization is closely related to the duration of chronic internal carotid artery occlusion. In a 1981 report by Hafner and Two among 47 patients who underwent carotid endarterectomy, the overall recanalization rate was 68%. Specifically, the recanalization rate was 100% for patients with occlusion duration of less than 7 days and 50% for those with an occlusion duration of 1 month. The current treatment strategies for acute ischemic stroke caused by CICAO include intravenous thrombolysis and intravascular thromboectomy, and so on. Meanwhile, for the treatment of CAO in stable phase, hybrid surgery has gradually become a potential strategy. Let's take a look at the main advantages and disadvantages of current treatment strategies for acute ischemic stroke caused by CICAO. Intravenous thrombolysis is effective in the treatment of acute ischemic stroke, while its efficacy in CICAO patients has not been fully verified. It may increase the risk of severe intracranial hemorrhage and death. As for endovascular mechanical thromboectomy, it has improved prognosis of ARS secondary to CICAO. Compared to thrombolytic therapy, EVT demonstrates significantly higher rates of excellent outcomes and lower rates of secondary hemorrhage. But it is not always possible to reach the distal end of the occlusion. Intervention procedures may lead to iatrogenic dissection, which can subsequently trigger thrombosis, new vessel occlusion, or new ischemic events. Penetration of the full thickness of the vessel wall may cause massive hemorrhage, increasing the challenges and difficulties of recanalization. Besides, for patients with extremely tortuous blood vessels, it is impossible to establish a pathway and perform thromboectomy. For CICAO in stable stage, the main therapeutic surgery strategies include interventional surgery, bypass surgery, and hybrid surgery. Interventional surgery has advantages of simple operation with minimal trauma, while it has disadvantages of high embolization rate, prone to vascular dissection, low revascularization rate, and high surgical risk. Bypass surgery can restore partial blood flow and is a treatment option for patients who cannot undergo hybrid or interventional surgery, such as Moyamoya disease, but it can be limited by indirect revascularization with high complication rates, and it cannot establish forward blood flow. Hybrid surgery, also called combined surgery, surgical strategies, encompasses carotid endarterectomy combined with balloon embolectomy or carotid artery stenting. It enables the resolution of carotid stenosis by removing thrombus within the carotid artery or directly excising the distal occlusion through the true lumen, thereby enhancing the rate of vascular recanalization in CICAO. Currently, there are no randomized controlled trials investigating the treatment of carotid occlusion, nor are there any systematic reviews or meta-analysis regarding the efficacy of hybrid surgery in CICAO. A meta-analysis incorporating complete data from 464 CICAO patients who underwent hybrid surgery concluded that hybrid surgery is the combination of the advantages of open surgery and endovascular intervention, has a high success rate and a low risk of recurrence of stenosis and occlusion in the long term. According to this article, the average revascularization rate of hybrid surgery reaches 87%. The revascularization rate after hybrid surgery is significantly higher than that of interventional surgery alone. Below clinoid segment, hybrid surgery has significant advantages. The incidence rate of operative complications for hybrid surgery is 11%, which is generally low. The mortality rate within 30 days after hybrid surgery is 4%. Follow-up of target vessel reocclusion or restenosis with a follow-up time at least 3 months. An expert consensus recommendations for surgical indications show that patients with ICAO who exhibit hemodynamic impairment may benefit from vascular recanalization. Comprehensive assessments should be performed prior to CICO vascular recanalization surgery for prognosis prediction. For non-localized occlusions with the distal occlusion located at or above the clinoid segment, vascular recanalization is not recommended. Vascular recanalization is not recommended for patients without hemodynamic impairment. For localized occlusions at or above the clinoid segment or long segment occlusions below the clinoid segment, vascular recanalization treatment may be attempted if the assessment indicates a high success rate. And they mentioned that based on preoperative assessment for CICO with the original occlusion segment located at the origin of the carotid artery, it is recommended that surgery be arranged in a hybrid operating room. Now we are sharing a case of recanalization of chronically occluded left internal carotid artery via combined surgical strategies. The patient was 61 years old male. He was found to have a cerebral infarction in the local hospital 25 days ago and also found to have left internal carotid artery occlusion hypertension. No other chronic disease history, such as diabetes, 20 years of drinking history, 40 years of smoking history, 25 days of dual antiplatelet therapy treatment, and no other cerebral vascular disease risk factors. 25 days ago, the patient experienced impaired movement of the right upper limb, accompanied by deviation of the mouth corner and unclear speech without any apparent cause. A cranial MRI plus MRA scan in local hospital revealed acute cerebral infarction in the left frontal parietal temporal insular loop, severe stenosis or occlusion at the origin of the left internal carotid artery, and the stenosis of the left anterior cerebral artery and the left middle cerebral artery. The patient was treated with blood activating, antiplatelets, and lipid lowering therapies as symptomatic treatments. Physical examination showed that the patient was conscious, in good mental condition, and spoke fluently. They followed instructions. He followed instructions for activities and cooperated with the examination. Bilateral pupils were equal in size and round, with a diameter of approximately 2.5 micrometers, and the light reflexes were present. The right nasal labial fold was slightly shallow, and the tongue protruded centrally. Neck rigidity was absent. The right upper limb had a muscle strength of 5-, slight weakness, while the remaining limbs had a muscle strength of 5. Babinski's sign was negative on both sides. Local hospital MRI DWI phase shows high signal in the left temporal parietal lobe and the low signal in the ADC phase, indicating acute cerebral infarction in the corresponding area. This is his MRI T1, T2 phase image. There is no obvious manifestation. MRI in local hospital showed left internal carotid artery occlusion. 25 days later, CTA in our hospital showed left ICA C1 segment occlusion, while left middle cerebral artery is visualized. CTA maximum intensity projection shows left C1 segment occlusion, right side normal. Bilateral vertebral artery CTA shows mild to moderate stenosis in the right vertebral artery, while the left vertebral artery is normal. CTP shows low perfusion in the left frontal parietal and temporal insular lobes. Left ICA shows equal signals and slightly high signal on HRMRI from bottom to top, with no significant high signal observed in the occluded distal end, indicating no fresh thrombus. CE enhancement shows significant enhancement and high signal intensity in the initial segment, while the distal segment remains mostly isointense, indicating that the occlusion is not a newly formed thrombus. HR high-resolution magnetic resonance imaging reveals the formation of atherosclerotic plaque in the left internal carotid artery with distal occlusion. Based on the above information, the preliminary diagnoses are left internal carotid artery origin occlusion, hypertension stage 3, high risk, cerebral infarction, recovery phase. When considering the surgical procedure, considering that the proximal plaque is prone to bleeding, the stripping procedure is chosen. Due to the absence of new thrombus in the distal area, interventional procedures are also being considered. Then the patient underwent surgery and cerebral angiography was performed before carotid endarterectomy. After carotid endarterectomy, endovascular stent placement procedure was performed. DSA during the surgery showed that the initial segment of the left ICA was occluded, and the external carotid artery compensated for the intracranial segment of the internal carotid artery through the ophthalmic artery, which could reflux to the petrous segment. DSA showed that the origin of the right internal carotid artery was normal, but the middle image revealed that the right anterior communicating artery was open. The origin of the right vertebral artery showed severe stenosis, while the intracranial segment was normal as shown in the right image, and the left posterior communicating artery was open. The origin of the left vertebral artery is normal with a normal intracranial segment, and the posterior communicating artery is open. Using An 8F guiding catheter. It was advanced to the origin of the left internal carotid artery. Angiography revealed a rounded and blunt vessel configuration at the origin of the carotid artery. Then comes the surgical procedure. During the surgical procedure, the neck was exposed. The neck was exposed and incision was made to access the carotid arteries. Initially, the common carotid artery was clamped, followed by the sequential clamping of the superior thyroid artery and the external carotid artery. A longitudinal incision was made along the CCA and ICA. Revealing a hard plaque occluding the entrance of the ICA, CCA, and the ECA. The hyperplastic and the calcified intima was meticulously dissected and stripped. The surgical site was flushed with heparinized saline, and any residual intimal debris was carefully removed. The vessels were alternatively opened and clamped to allow for appropriate back bleeding and repeated flushing with heparinized saline. The carotid artery incision was closed using 6-0 running sutures. Near the end of the procedure, the ICA was reopened first to expel any air and the residual intimal debris through back bleeding. Upon completion of the suture, we proceeded with the interventional procedure. A micro guide wire guided an SIL-10 microcatheter through the occluded segment of the left ICA. Microcatheter angiography demonstrated the true lumen of the vessel. The true lumen of the vessel. And a wall stent was then 940. A Wastent 940 was accurately positioned and deployed across the stenosis. However, the petrous segment and the origin of the ICA still showed approximately 50% stenosis. Therefore, an XIECE alpine stent was implanted in the petrous segment, partially overlapping the upper end of the wall stent 940. Additionally, a wall stent 930 was placed at the origin of the ICA, covering the lower end of the wall stent 940. Post-stenting angiography revealed excellent imaging of the ICA system, and the procedure was concluded. Postoperative management includes immobilization of the right lower extremity for 24 hours, close monitoring of blood seepage from the incision on the neck, strict blood pressure control, administration of low molecular weight heparin. Postoperative MRI DWFs and CTA showed no new infection and blood vessels were patent. After 9 days of hospitalization, the patient was discharged and the physical examination showed new positive signs. The patient was advised to rest, take medication according to medical advice, strengthen rehabilitation, control blood pressure, and arrange a CTA follow-up after 3 months. My sharing is ended. Thank you all.
Thank you, Dr. Xiao. Yeah, thank you. Nice, fantastic cases and successfully treated by the hybrid surgery using a recanalization of the carotid artery using a CEA and followed by the CAS procedure. Congratulations on your successful procedure, and that's good. Fantastic strategy to treat the patient with a chronically occluded internal carotid artery occlusion. So I have several questions here. So how many cases do you experience such a chronically occluded cases in your hospitals? So maybe it's a so rare case even in a huge number of cases treated in your hospital. I just want to ask you about how many cases this kind of patient or chronically occluded cases with a hybrid surgery. Thank you.
More than 20, about more than 20.
More than 20. Really? Abruptly recanalize the high flow to the affected cerebral brain. So it may cause to sometimes, I think, the hyperperfusion postoperatively. Hyperperfusion. So how to manage the postoperative hyperperfusion for the impaired cerebral brain?
Blood was controlled to about 110 to 120 to control the blood pressure.
We check the
And the CT need to be re-examined.
Okay, and my last question is, how do you decide the hybrid surgery for the chronically occluded patient? Maybe some patient, so for example, a severely occluded ICA can be treated by the only stenting.
Based on the imaging results, such as the CTA and HRMRI, there may be some indications for the hybrid surgery. Besides, we consider the duration of the occlusion time. We take these factors into consideration.
Yeah.
Duration.
Thank you. I enjoyed it a lot. Thank you.
There are no questions in the chat box, and I think we can hear your concluding remarks, Sensei.
Today we enjoyed the two fantastic presentations. First presentation was Professor Pierre, and he gave us a fantastic procedure for the anterior sclerosis tumor pathology using endonasal endoscopic approach. The next speaker is also the fantastic presentation for us to enjoy a lot. He talked about the chronically occluded ICA for treated by the hybrid surgery. Thank you for your fantastic, wonderful presentation. We enjoyed, we learned a lot as well. Thank you.
So I'll close this officially now on behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato. I would like to thank both speakers of today, Professor Pierre-Olivier Champagne and Professor Xiao Qiang on behalf of Professor Liu Dianwei, and the chairs Prof. Prakash Nair and Prof. Hidayat Kimura for the time and support for the ACNS webinars. A special thanks to Professor Shubin for broadcasting this on the WeChat channel, and as I mentioned earlier, we have around 910 people who have logged in through all different channels. So until we all meet online tomorrow, it is bye bye from all of us. Thank you very much for joining.